Thank you. You can hear me? Great. Good afternoon, everybody, and welcome to our third pancreas session. Gecko is hosted by the Gastro Foundation in association with Project Echo, the University of New Mexico. And these sessions are held weekly on a Wednesday, and the chat will be open for questions. It's quite exciting today. We've got an HPD surgeon, Dr. N Lahoud, who works at Chris Hani Baragwanath Academic Hospital, is a joint staff at the Wits University, and also runs a private practice from Sunning Hill. So we're really looking forward to a talk. And today she's going to be talking to us about resectable pancreatic adenocarcinoma, as well as borderline resectable pancreatic adenocarcinoma. So Dr. Lahoud, over to you.
Good afternoon, everybody. Thank you, Prof. Thanks for the opportunity to present. I'm just going to just share my screen with everyone so that we can get going. Okay, great. So we are going to speak also about, the topic is what are the options available for resectable pancreatic adenocarcinoma, and we're also going to talk into borderline resectable. So we're just going to start off with a few cases. So our first case is a 62-year-old female. She presented with obstructive jaundice with no cholangitis or pruritus, with about a 5 kg loss of weight and no other symptoms. Medical history, she is RVD positive, and she's been on ARVs, and she's virally suppressed for that. She's also type 2 diabetic on metformin, which she was actually quite well controlled. And only of note on the surgical history, she had a previous laparotomy in 2010 for a hysterectomy. She's got no personal or family history of having any kind of malignancies. So clinical examination, she's a fit lady. She had an ECOG status of 1, and the only thing really of note on her abdominal exam was a palpable gallbladder. So if we just quickly look at her results, sorry, this is how, just quickly, her white cell count was 6, her HB was 12.8, platelets were 272, she had a normal UNE. And if you look how we write our LFTs, her total billies were 130, and her conjugated 92, where she had a total protein of 59 and an albumin of 34. Her ALP was 2,349. Her gamma GT was 568, and she had an ALT of 468 and an AST of 294. INR was 1.05 and an HbA1c 7.9, which is fairly well controlled for a type 2 diabetic. So I'm just going to take us through her scan. Okay. And then I just would like maybe a few hands in the audience after seeing the scan. If we can look, this is a portovenous phase, it's an axial phase of a CT scan. See the liver coming in, and what we do see is we see markedly dilated intrahepatic ducts with a dilated common bile duct, which is over here, and then quite a dilated gallbladder. And if I stop it right there, so hold on, let me just go back a little bit. Stop it right there, you can actually see this cystic looking lesion in the head of the pancreas. Okay, I'm going to just take it a little bit further. I'm just going to slow it down for everyone. And if we're looking for a dilated pancreatic duct, she probably just has a prominent pancreatic duct, but not really dilated. But if you do follow it down, it stops in that mass, but it's actually not dilated. And we thought it was actually free of all the main vessels, so her portal vein, her SMV, her SMA, as well as her common hepatic artery. So we were quite happy with her. And that's what was our thought. Would anyone so who would, just out of interest, if someone either you can either type or maybe a few people can answer, who would offer this patient upfront resection? Prof, I don't really think I can see anyone. Maybe we should
I
just.
can't see any hands, but maybe we can ask Chrissy Madela. I see you on, Chrissy. Thank you for joining, Chrissy. Maybe you'd like to tell us what your options would be here. Chrissy, can you hear us? Yeah, maybe you can't unmute. So let's try I see Dr. Barner is on. Dr. Barner, if you can hear us, would you maybe suggest what you guys would do?
Hi, can you hear me?
We can hear you.
Okay. Sorry, I just missed the first part of the history. But from what I see here, it looks like a resectable head of pancreas mass that's um, somewhat cystic in appearance. Um, so in terms of what we would do next, I think there's a few options. There's the option, as Nicola mentioned, of upfront resection. Or the other option would be to go for biopsy of this and then for possible neoadjuvant chemo prior to resection, which is
So if
what
we could ask what
we
option,
would do here.
Melanie, hi, what option would you follow?
So we would do the neoadjuvant chemo first. So we would do an EUS and a biopsy first, and then biliary drainage, because I see the system is also up and the bilies are raised, and then start with neoadjuvant chemo first.
No problem. Okay, I think we'll ask another question on another case prop. All right, so we didn't decide to do an EUS and biopsy. We had enough evidence. We thought that this was a resectable pancreatic adenocarcinoma, and we went ahead and we did a resection for her. Are my slides moving? No,
No, they aren't.
they're not. Is the video moving?
Yeah, the video
Right.
No, it's
is.
frozen at the
We
moment.
mentioned we did a Whipples for her, and that's the specimen, and we can actually see the tumor in the head, which came off nicely, and we actually got really good margins. Unfortunately, she did have 2 out of our 27 lymph nodes positive, and all her margins were actually clear. And she's gone on to have adjuvant chemotherapy, so she's still in the adjuvant phase, and she's doing well. She's quite a strong lady. She recovered really well from her Whipples. Prof. Devar did it, and she was home in about 70. She was home in about 10 days post her Whipples. All right, so this is another case. Is a 55-year-old female. She presented to us with obstructive jaundice, also no cholangitis. She was puritic. She had about a 10 kg loss of weight. Of note on her medical history, she was hypertensive on 2 agents. She's quite significantly jaundiced. She had an albumin of 27, which you can see, with a normal FBC, and her UNE was normal, so was her INR. So we're just going to have a quick look at this case. Again, sorry, this is more the arterial view. This first starts with the arterial. We apologize for the content. We unfortunately have to video our videos. We have no way of downloading them at Barra anymore. So if we look, okay, this is an arterial view, just looking for vessel involvement, her SMA actually, we'll see the SMA coming off now. It actually looks clear. And her common hepatic artery also looks quite clear there, but let's just move on a little bit. I'm just going to speed it up for time to get to. It's not a great, I apologize again, it's not a great phase, but this is a portovenous phase. You can appreciate there's dilated intrahepatic ducts as well as a dilated common bile duct. Also not really a pancreatic duct, but there is a tumor appreciated in the head with some abutment of her portal vein, which we thought about was nearly close to 180 degrees. So we termed this patient borderline resectable. Maybe, Prof, you want to, just because if I log out, if you can maybe ask someone else if they agree with us and what they would do.
Sure. I'm just trying to go through the list of people that I recognize. Let's speak to Kiasha, Dr. Singh, if you wouldn't mind telling us your thoughts. Or Dr. Chaggy, anyone, don't be shy.
Hi, Prof. It's Nkoli.
Hi, Nkoli.
Well, if the patient is borderline resectable, then the patient would need an EUS and biopsy and neoadjuvant chemotherapy, and biliary drainage then would be required by that. because your chances of getting an R0 resection in a borderline resectable patient is quite low. So that's what I think would happen for the patient.
Okay, over to you, Nick.
Okay, great. So thanks, Jackie. We did exactly that. We did an EUS for her and we did a biopsy and we got back a pancreatic ductal adenocarcinoma, and she's gone to have neoadjuvant therapy, and we'll also see how she does. Okay. So our last case, which just wants to show a few things here, it was a 41-year-old female, so a really young female. She also presented us with obstructive jaundice. She unfortunately had cholangitis at the time, and we did an EUS and ERCP for her because at that time, I'm going to just show you what her lesion looked like in the beginning when she first presented, but she did have features of cholangitis. So again, it's a portovenous phase. There's a hemangioma in the liver, up in segment 4A. You can see a portal vein coming through, and she's got markedly dilated intrahepatic ducts, very dilated common bile duct, okay, and dilated gallbladder. And if you follow it, she's got quite a dilated pancreatic duct, if we follow it from the tail. And as it comes into the head, okay, it will stop around about there. Oh, sorry, it doesn't want to hold for me. Just trying to get it to where the action is. Okay, so it stops around about there, and there was involvement of her portal vein. So we opted to actually, well, we first opted to sort out the cholangitis, and we stented her and we settled her down, and then we landed up getting tissue which confirmed pancreatic ductal adenocarcinoma, and she went on to have FOLFIRINOX, okay? And this is her, she's post 5 cycles of FOLFIRINOX, and that we were asked to rescan her at that point. And I just would like to show you her scan and maybe just get some feedback from the audience what they think of when you scan. So again, you can appreciate that hemangioma coming in. So I'm not going to really talk much out. I just want the audience to just run through the scan and see, and we can get some feedback. I'll go a little bit back onto the pancreas again. And see, we put in a fully covered metal stent for her. Right. One last person, what they think of what's happened to this lady.
Um, have a look, non-Tokozo. Anyone that would like to offer? Mohammed, I see you on as well. Yeah, Michaela, maybe you want to give it a go.
Okay, from the city boss adjuvant, so I'm seeing that look at the pillar stand there's some hemophilia, as well as I think there's quite a response like from the chemotherapy from the lesion, so it's quite reduced in size, which I think the patient has responded quite very well, like in terms of the adjuvant chemotherapy. And then the slides, we say this apartment of the SMV on the view that I'm seeing here, but I would like to see like the full video as well. Yeah. Thank you.
Thank you. Dr. Lahoud, do you agree with it?
Okay.
So no, so
Go,
after
go,
someone
go.
speak.
Yeah, I think it was Zahir.
Oh.
Please go ahead, Zahir.
Okay, so just so what we can see, thanks for that, Yamkela. So what actually, it's not good news for her. If you look carefully, she's actually, if you look around her SMA now, okay, if you look right there, okay, there's tissue that was not there prior, okay. So it actually looks like this tumor's progressed on your adjuvant. And we actually worry that her tumor, instead of regressing, is actually progressed. And she's hasn't responded like we wanted to, and that actually just points to tumor biology. So I just wanted to give us three scenarios, and we have different ways. One we're quite certain about what to do with is the borderline resectable patient, okay, and to give therapy for. But the resectable patients is still a huge debate, and we're going to go into those, and we're going to talk about some of the evidence and see if we can make any leeway after this and have a great discussion. Okay, so pancreatic ductal adenocarcinoma is the fourth leading cause of death, of cancer death, related death in the USA. Sorry, in Europe, and it's the third cause of cancer-related death in the USA. In 2023, it was estimated about 64,000 patients were diagnosed with PDAC, and out of those, 50,550 people demised from this disease. So it's got quite a dismal disease and quite dismal outcomes if you look at it. And only about more than 80% of patients on the initial presentation will actually present with irresectable disease. So maybe the physicians are looking at us and saying, actually, what are the surgeons trying to do with this? But, okay, for now, we know that our standard treatment for this sorry, guys, my screen just went away. I apologize. I don't know what happened. Just flicked away. Is it back, Prof?
Yes, it's back.
Sorry about
We're
that. Okay.
beginning. No
So the
problem.
standard treatment for resectable disease is usually surgery followed by modified FOLFIRINOX. And when you just look at about a modified FOLFIRINOX, they give about 75% less of the dosage, and they're trying to lessen the toxicity. Okay. Currently, as we stand in 2025, okay, a quarter of these patients will have recurrence within 6 months. And if you look at the 10-year overall survival after resection of patients, is only less than 4%, which is also quite horrific facts to think about. A disease can do so much, okay? But the vast majority of patients with local disease on imaging already have metastatic disease. That's what we've also got to think about with this disease. And this also underlines the importance of systemic therapy in PDAC. And that's why we're trying, and there's been so many trials to see, should we be giving neoadjuvant, should we be giving more systemic therapy as opposed to going directly straight for surgery. Just to look at a little bit of how we've come and the evolution of pancreatic cancer, because we're far better than we were in the 1980s, in the 1990s, and in the early 1900s. So, just to look at it in between 1890 and 1930s, it was the first pancreatic surgeries. Initially, they did a distal pancreatectomy, and then Dr. Alan Whipple came along, and in 1935, he did a two-stage procedure for a Whipple. And then he did his first one-stage procedure as we do it today in the 1940s. Okay. Then in the 1970s, that's when we found chemotherapy agents with 5-fluorouracil and radiation. In the 90s, then we started improving our mortality associated with Whipples, because there was a huge mortality associated with it. And we came up with the concept of, should we be giving these patients adjuvant chemotherapy then? Okay. Then what came along was in the 2000s, we looked at the gemcitabine, the role of adjuvant therapy. The SPAC trial came along, okay, and they confirmed the benefit of your SPAC 1 and 2, confirmed the benefit of adjuvant therapy. The 2010s, then we actually came up with our regime that we currently use, and this has changed pancreatic cancer and the response and how the tumor responds to chemotherapy quite significantly. You looked at FOLFIRINOX, and for patients that were less fit, gemcitabine, and it's improved markedly. And then as we grew up, as we got more into the later on into the 2010s, adjuvant gained quite a big ground in borderline cases and in your neoadjuvant theories. Now, when we've come into the 2020s, okay, as we're moving forward and into the current age, we're looking at things, and Prof. Devar loves this, is that we're targeting and how everything's changing. So you look at precision medicine. So you're targeting patients' genetics, their lifestyle, their environment, and you're individualizing each patient, and you're moving towards precision medicine. And we've come up with immunotherapies, and this is going to change change our neoadjuvant approach quite markedly. So we're in a far better position than they were when they did the first Whipples in 1935. So I thought I'd just take us through the ages and see how well we've actually done. So decisions about diagnosis, resectability, and management should involve a multidisciplinary consultation, and it should be done in high volume centers where you've used appropriate imaging to adequately stage these patients, okay? And that's coming from the current guidelines in the NCCN, and we surely do, we definitely practice this where we take all our cases to an MDT, and then we go through and we've got quite a large HPB unit in our hospital. All right. So just when how, so these patients come in, you obviously the first thing you do is you look at the patient before you look at are they resectable or not. So you've got two tiers here. You need to first look at a patient, see that they are fit enough because you need to be, if you're going to give a patient chemotherapy, they should actually be fit enough for surgery. Okay. So make sure that they are fit enough and you've optimized them as much as you can with their comorbidities and they can tolerate the drugs we're going to give them as well as any kind of surgery that you're going to do on them. Right, once you've analyzed your patient and if you think your patient is operable, then we will talk about now we look at the tumor and is the tumor resectable. All right, and there's many guidelines that you can use, but we actually focus on the NCCN guidelines. And in terms of resectability, I think, Prof, do you want to just maybe quickly take over and show the pictures do the part for resectability?
Cool. If you could just stop sharing for a
Yeah,
second.
sure.
Thank you. Okay, so just having a look here, what we can see is that um, a combination of surgery and chemotherapy is still really the best option here, but reminding us of our anatomy and how intricate the vasculature really is with the celiac and the common hepatic artery being very close by, the superior mesenteric artery and the superior mesenteric vein. And this is a little bit of a sort of misdirected vision because the superior mesenteric artery really sits behind the superior mesenteric vein. But if we look at a tumor that's located in this area here, we all would agree that a stock standard Whipple would be something that we could achieve. But what about a lesion sitting over the common hepatic artery and encroaching on the celiac axis? And what about this lesion, which is sitting along the superior mesenteric vein and encroaching upon the superior mesenteric artery in this area here? And these are really the issues that we really need to look at. And so if we look at the axial visualization of this, there's a duodenum. This is the ansonate process. Here's a superior mesenteric vein, which you can see. Here's a superior mesenteric artery. The left renal vein is quite important as a landmark to find the superior mesenteric artery. And if we look at this, you can definitely see that we could probably take that out. There's a gap between the superior mesenteric artery and the superior mesenteric vein. But when you look at this, you can see the tumor has really occluded the superior mesenteric vein and the superior mesenteric artery. And this probably is going to be more locally advanced than anything else. And then we have this version here, which we can see, which shows the actual tumor encroaching on the superior mesenteric vein and not really on the artery, but you can see it there in its sort of difficulty for us to make up a decision in our own mind. Can we take this out? Shouldn't we take this out? And that's the kind of lesion that we talk about being borderline resectable. So I'm going to probably just show you a few more. So this is the actual CT version, and you can see there's a stent here. Here's a hypoechoic lesion. You can see almost this eyeliner between the actual superior mesenteric artery and superior mesenteric vein, and we can really drive our knife through that and take that out. Well, when we look at borderline resectable disease here, you can see here's this tumor. You're getting tear dropping and narrowing of the superior mesenteric vein. Superior mesenteric artery is still spared, but if we have to try and drive a knife through this, we're going to run into a little bit of trouble. So this is really a borderline resectable lesion. I'm going to stop there and hand back to Dr. Lahoud.
Thanks, Prof. That was great. So Prof simplified all the stuff that the NCCN has taken us through in the classification. Okay, I'm just going to get back to there for us. All right. So just looking at how we get in and what's currently available and what's new for resectable disease. Okay, so we're really pushing and the world is pushing to actually get them before any surgery is done is to get them into neoadjuvant therapy before they're trying to move away from upfront surgery and rather get into neoadjuvant therapy. So it's really had an increase in use in clearly resectable disease. And this was, you see, in our PREOPANC 1 study, which I'm actually going to go through now. All right, and we've moved into this adjuvant therapy, and FOLFIRINOX has become the standard of care provided that patients can tolerate it because it's a really toxic regime, and that's why modified FOLFIRINOX has come about, which I've said, okay? Again, what I said is that you can consider gemcitabine and paclitaxel in less fit patients. So now what's also emerging when you do liquid biopsies and you're looking at circulating tumor DNA, and this is going to risk stratify your patients, and you're going to see what the DNA is in the tumor and in your patient, and you're going to be able to offer so many more options for them. And this is really upcoming, and we should all be aware about this, okay? What's new for borderline resectable diseases? So we know that neoadjuvant therapy is the standard of care, okay? As I said, simple, everybody gets FOLFIRINOX, if not gem and paclitaxel. But now we've come up with another multi-centered randomized control trial, which I'll speak a little bit about as well, is the PREOPANC 2 trial. And that's also ongoing. They're now also looking at radiation in the US. It's very heavy, okay? Still debated. You want to look at stereotactic beam radiation. It's more commonly used in selected cases. And you're really pushing to take these patients from a state where they can't be operated to a state that you can actually get them to resection, okay? And we talk about conversion surgeries rates, and you've actually seen quite a significant improvement with aggressive chemotherapy regimes, and the fact that we've moved away from just gemcitabine alone, okay? Very important, and we keep on going back to this with precision medicine and focusing on our patients is our molecular profiling. And you can look at they're trying to look at the KRAS wild type now on pancreatic cancers, like, just for colon, and also your MSI instabilities. Just when you're looking for high MSI instabilities, and then you're going to say, oh, these patients might actually benefit from targeted or immunotherapy, and this might come into play as well as giving them chemotherapy. So they're looking at a whole host of other systemic therapies in order to improve patient outcome. Okay, so we all talk about this upfront surgery versus neoadjuvant chemotherapy and resectable disease. So the thing is yes, we can definitely operate these patients that are resectable. Okay, we can go in there and we can do upfront surgeries for them, and they can recover from these surgeries. Okay, but the problem is about in stats worldwide is that about 40 to 50% of patients take much longer to recover. So they don't do their 4 to 6 week recovery. They go prolonged to 2 to 3 months, and sometimes they lose that window. Okay. And I think we're moving to the question is, should we operate? Is it the right thing to do upfront surgery for these patients? Or is it actually better to rather give them the systemic therapy, let them have some neoadjuvant chemotherapy, let the chemotherapy target the cancer cells, because we think pancreatic disease maybe is a more systemic disease, and then go ahead. So can we or should we? We still don't know. There's big controversy around it. We looked at the PREOPANC trial, and I'm going to go into that right now. And just to look at why do centers prefer neoadjuvant therapy, okay? They say that a higher number of patients actually receive systemic treatment than surgery. So they feel that more patients are probably fit. And obviously, it's because you recover, you don't need any kind of recovery. You can go on to, once you're drained, you can go, if you need drainage, or if you don't need drainage, you can go straight onto chemotherapy, and you can initiate it as soon as you get tissue. Fewer patients undergo futile surgeries and R1 resection and R0 resections. Okay. You have less node positivity with neoadjuvant, less lymphovascular invasion, and less perineural invasion. And they think, and this is probably going to improve your overall survival, but we haven't proved that yet. And actually, what the most important thing is, as we saw in our third patient, it actually allows you to test the tumor biology, all right? And it gives you a chance to see, because if these patients progress on neoadjuvant therapy, there's no way that we should have operated on them because we've done them an injustice, okay? And if they regress or they stay the same, and this tells you, hang on, they might have a fighting chance. So I think the most important thing is you're able to assess the biology of the tumor. So now we look at this trial that came around, and it's done by the Dutch Pancreatic Group, and you looked at preoperative. They use chemoradiation versus immediate surgery for resectable and borderline resectable pancreatic cancers. Okay, and this is your PREOPANC 1. Okay, and if we look into it, it's a phase 3 multi-center randomized control trial done in the Netherlands. resectable or borderline resectable pancreatic ductal adenocarcinoma, and then the one arm you went for neoadjuvant, okay, and they used gemcitabine, so they didn't use what we currently use, okay, and they gave 30 gray, then you operated if you could, and you give adjuvant gemcitabine again, okay, or there was the upfront surgery arm, and this was for probably the resectable patients, and then they got adjuvant gemcitabine, so it's a little bit different to the chemotherapy regime now. And the downfall is they included borderline patients into this. And we actually want to know, what should we do? Because we know what we should do for borderline. But what should we do for resectable patients? Okay. So when you look at it and you look at your median overall survival, which is the biggest thing, and that was the primary endpoint of this trial, it didn't really make a difference. The neoadjuvant team got to 15.7 months, and your upfront surgery team got to 14.3. So there was no statistical significance there. Your R0 resection rate, though, was much higher in your neoadjuvant group at 71% versus your upfront surgery at 40%. Your disease-free survival improved in the neoadjuvant group, and the toxicity between the drugs and the regimes were actually comparable between. So, problem with the study, their primary point was they wanted to show that it improves overall survival. They couldn't reach that endpoint, okay? But it improves your R0 resection and your disease-free survival, and you're trained toward, you want to try and improve this overall survival. So they want, obviously, with your newer chemotherapy agents, will it have benefits, especially in the borderline patients. And it actually supports neoadjuvant therapy as a standard in borderline resectable PDAC, which we know, okay, and which we're practicing currently, right? So just a little bit about the locally advanced disease, what we should do, okay? And what's new for it, we use induction chemotherapy. So we give them definitive chemotherapy. We try and see if we can give them chemotherapy for FOLFIRINOX, okay? They might, in some centers, maybe in some very high volume centers in Europe, you might have a high conversion rate to resectability. We definitely don't see that in ours, okay? Unfortunately. Is there a role for radiation? Still controversial. There's a LAPO7 trial. It didn't really show much benefit, but it did improve your local control and your pain control. And there are ongoing trials to try and assess this, okay? Again, we're looking at, very importantly, and it's always coming up, is immunotherapy and your targeted therapy. And again, we're looking at BRCA mutations. They're looking at your neurotrophic tyrosine kinase receptor and receptor kinase mutations and your MSI instabilities. Okay, so if we look at what's going on here, okay, we've still got the PREOPANC 2 and the PREOPANC 3, which I'm going to talk a little bit more about the PREOPANC 3. The PREOPANC 2 trial, actually, so what they did is they're looking at total neoadjuvant FOLFIRINOX versus neoadjuvant gemcitabine, and then giving adjuvant, okay, and then the adjuvant setting, all right, and they actually looked at borderline. So this is not really about upfront surgery. Is it beneficial or not? This is looking at different kind of chemo regimes in resectable and borderline. Okay, so they're looking at what neoadjuvant therapies of choice. Okay, and we feel that probably support FOLFIRINOX, but we'll wait to see what the outcome is. There's an SPAC5 trial coming along, okay, which they use various neoadjuvant options for surgery, and they're looking at a 1-year overall survival. Yeah, okay. And again, the Porridge 44 trial is looking at which chemo regime, and these are ongoing trials, and we'll wait to see the outcomes of them. So we just need to look out for them. Okay. What we're interested in, because obviously we're surgeons, okay, is that we're looking at your PREOPANC 3 trial, okay, and that was where perioperative adjuvant modified FOLFIRINOX for resectable, that's the important part. Where the PREOPANC 1 trial looked at borderline and resectable patients, they're just looking at resectable patients, and they want to see, does it actually make a difference, okay? And then they'll do one arm or B, so we'll look at the one arm, they'll give their modified FOLFIRINOX, then they'll see if they can operate by restaging the patients, and they'll give adjuvant FOLFIRINOX, okay? And in the other arm, they will start with upfront surgery, and then you will get your adjuvant cycles of FOLFIRINOX, okay? So these are resectable patients, which makes it, we really like to see, will they improve overall survival in the resectable patients? So we're really looking forward to see what happens with this trial, okay? Just to talk about emergent therapies, okay? When they talk about organoid-based personalized therapy. So when you look at organoid, it's 3D models of organs created from your own patient and your own cells, okay? And they look at different drugs, and they throw these drugs from these cells that they've created, and they predict and they predict how the drugs are going to work, and this can guide your treatment. So that's really advanced, what we're talking about, but it is in the pipeline. Tumor microenvironment targeted therapy. Okay, your ctDNA guided decision making, which I spoke about earlier. Okay, and again, immunotherapies in combination in clinical trials start using them, and they are starting to use immunotherapy. They are doing a lot of trials with immunotherapy for these pancreatic adenocarcinoma patients and seeing if they can actually have any benefit them and prolong and get some, improved survival for them. Okay, so in conclusion, neoadjuvant therapy is increasingly favored in your borderline and your locally advanced pancreatic adenocarcinoma, and it's still being tested more in the resectable, which we can see. We're still debating it. A lot of us are still gonna go for upfront resection for these patients, okay? But it's still debatable, and people are trying to move towards neoadjuvant, really are, okay? FOLFIRINOX is the most studied and effective regime currently that we have, okay? Like I've been saying, there's this big debate, okay? And what we are waiting for is future studies in your PREOPRANK 2 trials and 3, and your PANACH trial, which is a PANACH Porridge 48 trial, which is a phase 2 non-comparative randomized controlled trial. And what they are again looking at is they're looking at neoadjuvant modified FOLFIRINOX or FOLFIRINOX versus surgery, and adjuvant therapy. And they're looking at the 12-month overall survival for these patients. So it's another trial that we'll also look forward to and see if it makes any way. Okay. And let's see what the outcomes are, and let's see if it's going to completely change the management to what we've had. So thanks, everybody. I'm going to just hand it back over to Prof.
Thanks, Dr. Lid. I just think that at this point in time, that whilst breast surgeons and the rest of, gastric cancer with the MAGIC trial and the FLOT trial that came up, when we looked at these, I mean, it's a no-brainer that we should be giving systemic chemotherapy. But having said that, I think we need a little bit more evidence rather than a PREOPANK 1, PREOPANK 2, or the PREOPANK 3 that we're waiting, because there was a really damning study that came out. And the damning study that came out was the NORPACT 1 trial. And if you looked at the NORPACT 1 trial, this was a multi-center trial run across the Nordic region, Sweden, Norway, Denmark, and they really had a significant number of patients with resectable pancreatic adenocarcinoma here. And when you looked at intention to treat, okay, the median overall, basically, the proportion of patients that were alive at 18 months was 60% in the neoadjuvant group, okay, versus 73% in the upfront surgery group. And then if we looked at the median overall survival in the intention to treat group was only 25 months in the neoadjuvant group versus 38.5 months. And I think that this really, again, showed us that we've got to be quite careful in how we interpret the use of neoadjuvant chemotherapy. And for the first time, we actually had a standardized neoadjuvant chemotherapy. It wasn't a hodgepodge of gemcitabine plus radiation or gem-nab or FOLFIRINOX or modified FOLFIRINOX. This was FOLFIRINOX in versus upfront surgery. And for the first time, we actually started to realize, well, maybe we're not doing better by adding the neoadjuvant chemotherapy. So I'm just playing devil's advocate, and you're quite right, Dr. Lahoud, that we need a lot more information around this prior to us following this routine. And I think what's more important is the role of precision medicine. And I think you are right when you say that. So you actually do understand the actual mutations, and not just the mutations in terms of KRAS, but understanding the pathways, the microRNA pathways, understanding whether the tumor upfront expresses PD-L1 or PD-1 receptors, and whether immunotherapy will make a difference to your particular tumor. Having to convince the funders and the people that we work with to actually give this kind of therapy upfront is another story. But I'd be really interested to hear just now about other people's experience, in particular Dr. Burmeister from Cape Town. But in order for us just to complete what's new in pancreatic adenocarcinoma and resectable adenocarcinoma, I just thought I'd share some data with you in terms of vein involvement, and when the vein is involved, having had this response to therapy, what can we do? And in general, like, we've forgotten this a lot of the time, and very rarely do we actually do any venous resections any longer because patients obviously either progress with metastases, distant disease, but for those that actually do have a response, and it might just even be a decrease in the CA 19.9, and they may not have radiological features that change too much. We need to make these decisions upfront, whether we will resect the vein or not resect the vein. And I thought it was important for us to debate this. What was interesting, though, is in that NORPAC trial, there was definitely a benefit to R0 resection. And this is quite an important thing. So the rationale to resect the vein is to improve this negative resection rate and actually clearing the lymph nodes. What techniques do we have to do this? Well, we can take a side bite, and I don't really enjoy doing this anymore because you get quite a kink in the vein and turbulent flow. And I'd really rather prefer to put a patch there. There's an option for an end-to-end anastomosis, which you can see in this case. Sorry, I should actually play the here you can see there's a kink in the vein that develops, and here's an end-to-end anastomosis that we've actually performed. Then we can actually do interposition grafts if it's a little bit longer. Generally speaking, I don't like to resect the vein more than 4 centimeters. These things retract and it's quite difficult to put together, but if we are, then an interposition graft, we can use an internal jugular vein, or the left renal vein can be used. What I have used is a falciform patch. In the past, people used to use the bovine patches, but a falciform ligament patch works very well. And this is something that we really shouldn't do any longer, because I've used large interposition grafts and invariably these clot. And with the survival that we're getting these days, I think that the results of this vein, this graft clotting and the portal hypertension that ensues is actually quite impressive, and patients actually sometimes die in our setting from the portal hypertension and the variceal bleeds that they develop over the years. But if we look at the vein resection reports, in fact, the morbidity is the same and the survival, overall survival is the same. So you don't jeopardize the patient by resecting the vein. The only issue is that we see that there's intraoperatively definitely a higher blood loss. If we look at the vein resection versus no vein resection, the survival is actually, there's no difference in survival, and maybe a little bit of a benefit with the Kaplan-Meier curve here. If we look at the NS script data, what we can see is there's definitely an increase in the 30-day morbidity, but definitely no increase in the 30-day mortality. What about arterial resection? Should we be doing that? Hepatic artery, should we be doing the SMA? Here you can see there's been a patch that's been put and arterial resection that's been done. And should we be doing this? You can see the arteries involved and surrounded here. And we have done them before. Should we be doing them? That's the question. And if we look at the data, if we look at the post-operative mortality, it's much higher once you've done these arterial resections, and your 3-year survival is much less in terms of patients that do have arterial resections. So if we look at the meta-analysis at this point in time, it's associated with poor short-term and long-term outcome, and pancreatectomy with arterial resection may be justified only in very highly selected patients. And these patients probably should be within the bounds of clinical trials rather than us bashing on as we try to. So, I think I'm going to stop there in terms of the arterial resections and the venous resections, and then I'm going to hand over to, or maybe ask Dr. Burmeister just to stimulate a little bit of conversation from Cape Town, just in terms of your approach as a respected pancreatic surgeon, and your rationale for use of neoadjuvant therapy in resectable disease. Sean, if you are listening, it would be great to have your comments.
Hi, evening, John. Thanks very much for that. Can you hear me? Is my microphone working okay?
Yep, perfect. Thank you.
All right. Well, first of all, thanks to Nicola. I think that was a great presentation. I think she really covered all of the salient points very well. So thank you very much for that. And thank you for asking me to comment. Yeah, I mean, I think, you've really highlighted the key issue at the moment in pancreatic cancer. And I'm quite excited to hear what they're working on, sort of more broad-based guidelines, which are going to be discussed at the European HPB meeting in 2 weeks' time. I'm very interested to hear if anything comes of that. But to bring it back, yeah, I mean, the key issue really is what to do with resectable disease. I think I think it's been well shown that for borderline disease, the benefit for a neoadjuvant approach is clearly there. And I don't think that there would be many HPB surgeons around the world that would be tackling borderline disease up front. But as you highlighted, I mean, the NORPAC trial, I think, has really thrown the cat amongst the pigeons to some degree. You know, it was actually PREOPANC-1, although the long-term data from PREOPANC-1 that was suggesting a benefit in resectable patients. And I think we were all kind of eagerly awaiting PREOPANC-3 to kind of prove that or give more evidence of that. So NORPAC has kind of taken us back a bit, or caused some, shall we say, some caution. However, I think for me, and I think the way as a team we look at it in Cape Town is that there's a paradigm shift in terms of what we think is affecting overall outcomes, in other words, long-term survival. And that is the degree of systemic disease that the patient has. So the shift from thinking, well, we're just dealing with a cancer in the abdomen to, well, that's where the primary is, but we know that there is circulating tumor DNA and RNA and the potential for later metastatic disease. And that's actually what is going to affect your survival. And so surely, so the first argument that we would make in favor of a neoadjuvant approach for resectable disease is surely you want to treat the disease that affects your survival first, and to get that chemotherapy on board before you control the primary, so to speak. So I think that would be the first argument that we made. And then I had a quick squiz again at the NORPAC trial before you asked me to comment, John. And I think it's notable that only about 80% of the patients who were randomized to the neoadjuvant group actually got their neoadjuvant therapy. So if that's our starting point, and we then go on to look at what proportion of patients get their adjuvant therapy after their surgery, that drops down even further. So, you know, if you've had post-operative complications from a Whipple, and we know that that's relatively frequent, and that delays you getting your adjuvant therapy, because there's no question surgery alone is not the answer. That I think we've established. So you have to get your adjuvant therapy. And if you've had a complication that prevents you from getting your adjuvant therapy, even if it's by a few weeks or 2 or 3 months, then that's probably not going to do you any favors. So for us, those are the two, and a significant proportion of patients will end up like that. And if you're giving your adjuvant therapy after more than 2 months after your surgery, I think you probably also need to be questioning how effective that's going to be. Not to mention what the specific complications that you've had, in particular sepsis or bleeds, need for transfusions, you know, how that has changed the inflammatory milieu and how that may have implications for recurrence of disease or development of metastatic disease. So I think just to summarize, those are the two reasons I think that we would push hard for a neoadjuvant approach in resectable disease. So it's to treat the systemic disease first and early, and to avoid patients not reaching their adjuvant therapy because of post-operative complications. Obviously, we've got to wait for the data, but that would be our thoughts on that, John.
No, I think
Thanks.
that's really summed it up quite nicely, and I think these are the real issues that we're grappling with. My biggest issue, though, is you do get patients that are not sensitive to FOLFIRINOX that progress, and then you get those that convert to gem, nab-paclitaxel, and then actually have a response to those patients. So it's about weeding out and understanding the biology, who will respond to what therapy, I think, more than whether we give systemic therapy or not, because for me, it's pointless giving a therapy that is not going to be beneficial. And right now we're giving just a stock standard recipe to everybody as opposed to precision medicine and understanding the individual tumor. In a way, it's a pipe dream of mine that each tumor that we have would be typed and we'd be able to give precision sort of chemotherapy. But I think it will come. I think it will come in time. We got to watch that space. So my only question to you is then, I know the Americans are very sort of pro this, is give all the chemotherapy upfront because of the potential complications and then do the Whipple. What we do know is that a lot of the chemo associated with this gives you a significant cash. There's a significant amount of sarcopenia that develops in these patients, and they're not as fit after they've had those numbers of or those cycles of chemotherapy, and we don't really have the answers to it now. I suppose it's a bit of an unfair question. So I suppose it comes down to, again, what are your guys' thoughts on giving all the chemo up front versus, watching and maybe 3, 4 cycles? And sometimes I feel like we're dabbling with this because we just don't have the evidence at this point in time. But your thoughts, Sean?
Yeah, thanks, John. So look, first of all, I'm very gratified to hear that. I think we're kind of on the same page on most of these issues. So first of all, I want to completely echo what you just said. I think to some degree the wrong questions are being asked. It's not should patients be getting neoadjuvant therapy or not. It's a question of which patients should be getting neoadjuvant therapy, okay, when we've got sort of the limited options that we do. And maybe one day when there are more options, it's which therapy should you be getting as neoadjuvant therapy. But this kind of, to me, it seems like it's a bit of a shotgun approach. You kind of, there you are with your cancer, you suitable for surgery, and we say, right, half of or some of you are going to get neoadjuvant therapy and some of you are not. And it's, to me, there must be a better way that we can be assessing that. And I don't think it's that far off. I mean, when we think about organoids and things like that, I don't think it's that far off where we can test the tumor's reaction to chemotherapy to help us make those decisions. Sorry, that was the first thing. Sorry, just remind me, the second question was?
All chemo or not upfront?
Oh, yes. Okay, so our standard is we would give 6 cycles. So we pursue a sandwich approach, a perioperative approach, and we would give 10 to 12 cycles, and we would usually give 6 before and 6 after. If we see that there is significant response, and obviously, yeah, so stable disease, we would still explore. Progressive disease, we would probably, depending if it was still resectable, we might go and resect, admitting that the prognosis is probably poorer. But if there was, if it was a borderline resectable lesion progressed to a locally advanced lesion on chemotherapy, we would definitely not explore that patient. I think the question really is okay, you've given let's say, so our patients would get a scan after their 5th cycle just prior to getting their 6th cycle and then a month's wait to surgery. If we see a tumor that is responding well, we might well ask the question or we might well pose the question of, well, shouldn't we continue until we've completed the full cycle, seeing as one's getting a good response? And that's only going to be of benefit, certainly in terms of your R0 rates. So I think if we saw a positive response, we would consider giving more chemo. But yeah, it would be an individualized situation. The other thing that I think is you alluded to is, I hear you that, FOLFIRINOX is quite tough on patients. But, if you look at MD Anderson's rationale, one group that they also strongly consider a neoadjuvant approach is in fact the patients who are, let's call it borderline fitness. And they would employ a neoadjuvant approach and a prehabilitation and a period preoperatively where they would look to optimize all aspects of the patient in terms of their fitness, comorbidities, general fitness state, general nutritional state, etc. And I think that that's also not necessarily a bad approach to take. If you've got a patient, you're unsure of their ability to tolerate the operation, especially, in our scenarios where we aren't always dealing with patients from the best socio-economic backgrounds. And I think that's one of the things is that we compare our figures to first world data, and our patients are not necessarily first world patients, certainly not all of them. And so I think there is potentially that benefit of the neoadjuvant approach in terms of optimizing patients for surgery.
Yeah. No, thank you so much for those comments. I totally agree with you, Sean. Thank you. I see Dr. Mandela's raised his hand. Please go ahead, Fusi.
Hi, Prof. Thanks for the opportunity and thanks for the presentation, Nicola. I just wanted to ask a question, particularly with regards to the borderline resectable disease. Do you not think that considering that most of the research around these topics are done in Europe, do we not think that the gap of polymorphism in terms of the response rates in our population is too high to the extent that it makes it almost prohibitive to adopt the concept of neoadjuvant for resectable disease?
So thank you, Fusi, for the question. I mean, to be quite frank with you, some of the data that we've been getting, and you're quite right, if we look at the diversity, and if you look at the Human Genome Atlas, only 10% of African DNA was included in the Human Genome Atlas. So we haven't really cracked the codes, and we don't really know if our mutations are similar. But from basic work that we've done within our unit, looking at the transcriptomics, looking at the GWAS, looking at the microRNomics on these tumors, some of the metabolites expressed, we're not a hell of a lot different. But we're talking about pancreatic cancer globally. We're talking about right now a recipe that everybody's using, that we've proven benefit to. So that's all we have. But the holy grail is what we were talking about, is actually typing each individual's tumor. And with the genetic diversity that we have, we may find that different things will respond differently. And maybe we're not even using the correct chemotherapy regimes. Maybe we're not even using the correct immunotherapy agents. I mean, for now, pembrolizumab is what we use in third line disease, but maybe we should be using something else. So we don't know that. And until we get to individualization and precision medicine, we will not have our own data. And until we start as a country getting together and starting to discover what our genetic mutations are, we're never going to know. So I hear the question, and it really calls for us as societies to get together, to start working together, to start getting registries and tissue biobanking together to get this done. So, I mean, excellent question. Thank you. I hope that answers you, Fusi.
No, it does, John. Thanks.
Thank you. All right. So maybe I can just ask Dr. Lahoud if she'd like to say anything else, or Dr. Lahoud, any other opinion from your side?
Prof, no, thank you. Thanks for all the comments. Thank you to Dr. Burmeister for giving us input into what they do in Cape Town. I don't think I have any further comments. Thank you for the opportunity to speak to everybody. Hopefully we can see what the future holds for us when these trials come out, and we can see if they hold any benefits and changes. But that's all from me. Thank you, Prof.
So I'd really just like to thank Nicola for putting this together. Thank you to iEcho, University of New Mexico, and the iEcho team, iEcho India team. Recordings will be available on the Gastro Foundation website. Really just once again, thanks to the Gastro Foundation and the initiative to include pancreas in these sessions. Really enjoying them and loving the speaker's approach. And then finally, thank you to our sponsors. And next week, it'll be hepatocellular carcinoma. So thank you, everybody.